We are live.
A very good evening, everyone. Welcome to Episode18 that is an OCULOPLASTY. And this is the 2025-26 edition with the aim to educate, elevate, and excel. And today we have, we can go to the next slide, Ananya. So we thank the AIOS dignitaries, Dr. Partha Biswas, sir, President AIOS, Dr. Santosh Naiva, sir, Honorary General Secretary, Dr. Manoj Mathur, sir, Honorary Treasurer, for drafting in the program so beautifully.
Dr. Rolika, you're not audible.
Dr. Ananya, I think you can take over.
Yes. So the speakers for today are Dr. Shahid Alam sir, Dr. Meenakshi Wadhwani, Dr. Raka Chatterjee, and Dr. Urmil Chawla. We have the expert panel, Dr. Maya Hara, Dr. Usha Kim, and Dr. Shahid will also be chiming in. Rolika did the faculty introduction here. The basics of eyelid reconstruction will be done by Dr. Shahid Alam. Management of congenital and acquired ptosis by Dr. Meenakshi Wadhwani. Role of botulinum toxin in oculoplasty by Dr. Raka Chatterjee. And lacrimal apparatus injuries by Dr. Urmil Chawla. We will start this session with Dr. Urmil Chawla. Moderating for you today, we have Dr. Rolika Bansal and myself, Dr. Ananya Apyankar Joshi. Over to you, Dr. Chawla. Ma'am, you're muted. You could share your screen and unmute yourself.
Yeah. Good evening, everybody who has joined. Good evening, respected Dr. Usha Kim, ma'am. Good evening, Dr. Maya. And good evening to everyone who's joining. Should I share my screen? At the outset, I really wish to thank Dr. Santosh Naiva, sir, for giving me this opportunity, and Rolika to moderate and coordinate with everything. Someone else is sharing, it's showing.
Ma'am, I've stopped sharing. If you could find the option share at the bottom.
Yeah, I can find and I'll share.
Sure.
So, are my slides visible?
Yes, Dr. Chawla, but you could be in slideshow mode.
Yeah. It's still showing someone else is sharing.
Ma'am, can you click on the first icon, play from the start? Yes.
Yeah.
Thank you.
Okay.
Wonderful. You can see, ma'am.
Just a sec.
Okay, it's visible.
Yeah, it's visible, but actually,
Just click on the screen. You should be able to move the slides also.
I'm being able. This thing is coming in between
It's not visible, ma'am. You can continue. It will
not
go
visible.
away.
It's visible to me actually, so it's disturbing.
Just click on the screen. It will go away when you start.
It's still not going. Although, just a second. Hide thumbnail. Just give me a second. Okay, I'll go like this only. Okay, so good evening, all the students who have joined. Today, my topic is lacrimal apparatus injuries, and I'll be covering. Can the support team help me with reducing this grid? It's just coming over my slides.
Ma'am, just click on the slides and keep on moving. It's not visible here. It will go away within 2 seconds.
And the slides are also not moving, sir.
And just click on the slides. Just click on the slides and move.
Okay.
Yes, it's moving now.
Okay. If this grid can be removed, just take care because it's coming over my screen. So it's hiding some part of my talk. That's why I'm getting troubled.
Ma'am, you can minimize Zoom and then it will go out.
I tried to do that, minimize it only, but it was not getting.
Ma'am, just long press on that window and move it on the right. That should do the trick. Just long press on it and just move while pressing, just move to the right.
Okay.
Otherwise, it's perfectly visible to us. You can keep rolling the slides if you want.
Okay. No, it's really disturbing me actually.
Ma'am, I'll just tell you what. Ma'am, just unshare the screen once and then share it again. You'll be comfortable once again.
Unshare the screen once.
Yeah, just unshare the screen
So I have to end show first.
and
Then,
and yeah,
Now share,
sure.
doctor, again.
unshare it.
Mahesh, it's stopped. You can share, ma'am, now.
I can share.
You can start the slideshow and then share the screen, ma'am. Is this okay now, ma'am?
No, it isn't okay, but
Ma'am, just click on the first icon. You should be good to go. Slide, start from the top where you clicked on the left hand side top.
yeah, that I've done. But this grid is again disturbing me actually, but I'll
Just click on continue to share on the screen.
okay, anyway, continue to share. Yeah.
Yes. Just keep on sharing and it will ghost away.
Okay. So, sorry for the glitch. Okay, we go ahead with the lacrimal apparatus injuries. So, as you all know, the lacrimal apparatus, it consists of the secretory part as well as the drainage part. The secretory part is mainly composed of the main lacrimal gland and the accessory lacrimal glands. However, the drainage part, it starts from the lacrimal punctum, then the canaliculus, the lacrimal sac, and the nasolacrimal duct. And when we come to lacrimal apparatus trauma, the frequency of trauma is mainly first to the canaliculus, more common being the lower one, then upper, and then the bicanalicular injuries can be there, the nasolacrimal duct, the lacrimal sac, and lastly, the lacrimal puncta may also get injured. These patients are generally patients of polytrauma, so we definitely need a team approach. So initially, life support care is the first thing that you should give. The ABCs should be followed by the site support care once you attend to them as ophthalmologists, the functional care, and then finally the cosmetic care should also be in your mind. Now, imaging is one of the very important thing when such a patient comes to you, X-rays to rule out otherwise. So it is always better to over-treat rather than under-treat. Timing of surgery, it may be an early primary repair within 24 to 48 hours, or it may be a delayed primary repair 3 to 4 days later after controlling edema or infection, and most cases are successful if repaired within 5 days. Now, lower canalicular versus upper canalicular injury, 80% of drainage, as we know, is through the lower canaliculi. However, most authors believe that all canalicular lacerations should be repaired, whether upper or lower. It is not that more emphasis should be paid only on the lower canaliculus. Now, I'll take you to the canalicular repair stepwise approach because that is the most common part of lacrimal apparatus injury. So, it can be done under local or general anesthesia. Need to identify the cut ends, pass the stent, do the suturing, do the margin repair, anchor the stent, and a skin closure in the end. I'll take it through you one by one. So you should keep in mind that whenever you're wanting to do a canalicular repair, your basic requirements should be complete. Try to do it in the operation theater always. Do not prefer going for early in casualties or emergency theaters. Proper anesthesia should be there, optimal illumination and magnification, and at times endoscope may be needed. As far as instruments are concerned, a basic set of lacrimal system instruments should be there with you. The punctum dilator, Bowman's probe, the olive tip, smooth tip dilators, probe, and even pigtail probe and stent if you are planning, if you need it for the canalicular repair, you should have it in mind. And of course, your thorough understanding of the anatomy of the medial canthus and how to go ahead it. It's very well said that the eye sees what the mind knows. So the more you are theoretically strong, the more you are prepared, you will be a skilled surgeon to go ahead with also. Now, localizing the cut end of the canaliculus is the first step. Proximal cut end is very easy. Proximal cut end is the end where the punctum starts on the lid. So that is still easy to be detected. You can simply pass the Bowman's probe from the punctum and it reveals it as you can see in these pictures. Now, distal tall end, the end which has been got severed, is the one that is difficult to be detected. And lighter, and how do you detect it? First thing, as a resident, whenever you go into the casualty, don't just be in a panic and just don't explore the area just with your swab sticks or anything. Be very careful, be very gentle, because the distal end, once it gets messed up in your exploration, it would be difficult to be found out. So, and once in the first go, you are able to see the best. And because it gets edematous after the injury, so it becomes whitish. You can see a whitish mucous membrane around that distal cut end, and it shines in the hematum because the rest of the area is having little bit of bleeding. So if it is hematogenous, so that edematous punctum may shine through it, and that is what is called the calamary sign. You can see that, and if you are able to detect that, that would be the best part. And localization can also be done in case it is not visible in under magnified view under the microscope. You can do a fluid irrigation from the intact punctum, maybe the upper or the lower, or you can use a fluorescent stained fluid or viscoelastic, trypan blue dye, or even air bubbles can be used, and this may help you to find the distal cut end. Now, once you have found, now it's in your mind that you have to go for canalization of the canalicular system. So keep your stents ready. The monocanalicular stents we may use, mini Minoka stent, to be more economical. If the patient is not affording, you can also use an IV cannula, 22 or 24 gauge, and celastic intubation may be done. However, mini Minoka stent is one of the common ones we are using. It is simplified repair. It helps in that. It maintains proper alignment, prevents stricture after repair. It is soft, pliable, and the silicone minimizes ocular irritation and tissue trauma. And you have that collarate part, which you can see over here. And then it is around, it's a long, you sometimes have to cut because this much long is not needed. So I'll tell you how to go about it. And for bicanalicular intubation, you have the annular stents, and you can do that with the pigtail probe. This is the pigtail probe in the diagram. It is passed through the intact canaliculus. It curves through the common canaliculus, like you are passing here through the intact canaliculus. It goes out, it comes out through the distal cut end. You thread it with a suture, and over it you can thread the stent also. Then you take this the pigtail probe from this end, and again you pass it from here, and you can tie a knot. I'll show you a small video. So this is the pigtail probe. You're going from the intact upper canaliculus. The lower part is severed. See, it has come out from the distal end. You are threading it with a Prolene suture, or you can use this, and you are also threading this suture with a stent. Now you will take out the pigtail probe. As you take it out, the stent is also coming out. So this way it is, and now you again go from the intact proximal end, again thread the suture with the stent, and you pull it out from this end, and then you tie the knot over here. So this is, sorry, it is, okay, I think I didn't. So this is how it looks after in the post-op period. Now coming to the bicanalicular stent, theoretically you should be knowing at your stage that there's a Crawford stent, there's a Ritlich stent also. Now, what are the complications of using these stents? They can create false anastomosis. Sometimes if too tight tubes are there, cheese wiring may occur, ocular irritation may occur, infection, local inflammation, granuloma formation, or very commonly extrusion of the tube may also occur, especially in case of mini Minoka stent. Now, what are the advantages and disadvantages? Monocanalicular intubation, it avoids manipulation of the normal canaliculus because you are only using it in the severed part. It is easily placed. Reduced risk of punctal injury and cheese wiring is there, and they are self-retaining and easy retrieval is there. However, the bicanalicular intubation, it alleviates tension on the suture tissue. It can be used as site of wound healing. It is suitable for upper and lower canaliculus. However, the disadvantage is that it has a potential for damage to the normal nasolacrimal duct and Hasner valve, and it is a cumbersome procedure with a learning curve attached to it. Now, after you have placed the stent, comes the next step of canalicular repair, and that is pericanalicular suturing. Wherever possible, 3 equally spaced 8-0 vicryl sutures are placed through pericanalicular tissue, and they are left tight until all 3 have been placed. The first you can pass at the gray line, then a posterior pericanalicular suturing should be done, and then the anterior pericanalicular suturing should be done. And then you are followed by the suturing of the lid laceration. Once you have done a pericanal, I'll show you the video. So once you have done with the pericanalicular suturing, you can suture with the suture the skin over the lid laceration. The medial palpebral ligament also should be attempted to be repaired by non-absorbable sutures posterior to the lacrimal sac, and the lid margin is sutured with 6-0 sutures placed in a vertical mattress fashion, and you should take care not to damage the canaliculus or the stent that you have placed. Finally, the stent, if in case you are using the IV cannula, it can be secured at the lid margin with the help of non-absorbable suture. This is again a small video. This is a case of canalicular. We are just passing the probe through the proximal cut end. We have, and now it at this stage only, before you go to the distal end, you pass the mini Minoka stent and make sure that at this stage only you are fixing the collarette inside the punctum by pulling the Minoka and little bit manipulation with your probe or any other instrument. Now, if you've already detected, you can pass a probe and measure also, and accordingly you can keep the length of the mini Minoka stent. Once you have placed the mini Minoka stent, now you start with the pericanalicular suturing on either side of the stent. First, once you tie it and oppose it and see whether it is okay or not, and then you can pass the rest of the pericanalicular sutures again. As I said, the posterior pericanalicular and the anterior pericanalicular suture with the help of 6-0 Vicryl only. And then you do the tying part and try that the stent is also getting secured with these sutures. And now you go ahead with your 6-0 silk. First, the lead margin is opposed, good apposition. And the first suture you can keep long also, so that you can use it for giving traction in the end. Or you can also, now since this suture we have kept long, sometimes it's better to give traction and lift the entire area against gravity towards the upper side. Now you do the rest of the suturing of the skin with the help of skin 0, as we do a routine suturing with 6-0 silk. Or else you can leave it like this. Now, this is when the patient can afford a mini Minoka stent. This is another case where the patient was not able to afford a mini Minoka stent. So again, we had used the IV cannula. As I said, that IV cannula 22 or 24 gauge is easily available in almost all OTs, very economical. And sometimes I would tell you it is better than mini Minoka while you are doing the maneuvering part, because the part is stiff and it goes very easily like a probe, and it helps you to detect. You make the needle end blunt, and then you go ahead with the entire IV cannula like this. See, now you are going to the proximal punctum and then the distal cut end. You go there, and then you can check it out whether it is okay. Uh, and then you start with the suturing part also. Now you're doing the pericanalicular suturing, the same as we did it with the help of the mini Minoka. In the same way, you will pass the sutures first at the gray line. You will see the apposition. Then you can loosen it all out also, and first pass rest of the two sutures. And then you can complete the pericanalicular suturing and securing the stent in place. Followed by that, you will do the skin suturing with 6-0 silk. You will cut the rest part of you've started with the skin suturing. And you can secure, after cutting the part of this, a little bit of stent that is left, you can secure it to the lid margin with the help of your sutures. So this way, if mini Minoka is not available to you, you can finally, and you can also put a bolster over there for better securing. So in cases where mini Minoka is not available, you can go ahead with this, and it is very economical as well as easy to do. Now, coming to the salient features, success rate with canalicular repair, if done with in good hands, can range from 20 to 100% even, and it rises to 86 to 95% if it is an early and microscopic reanastomosis of the severed canaliculus with silicone intubation is done. Delayed repair and dog bite injuries have a little poor result. And simple stepwise approach of canalicular laceration repair gives gratifying results in primary repair, and so it should be attempted. Now, lacrimal apparatus injury is not only about canalicular tear, even the medial canthal area can be involved. So keep in mind, whenever you have a medial canthal injury, thorough examination of the area should be done. A traction test should also be tried. You grasp the edge of the lower eyelid and the upper eyelid laterally and pull it against the medial attachment. You will see that the eyelid margin does not become taut and there's no bowstring if injury is there. It is often associated with canalicular injuries, but sometimes only medial canthal injury may be there. And repair of the posterior crus of the medial canthal tendon is critical in such cases. It can be repaired with 4-0 double arm Prolene. And if sometimes complete avulsion of the medial canthal is there, then definitely microplating and transnasal wiring may be needed. Now coming to the distal lacrimal drainage system that comprises of the lacrimal sac and the nasolacrimal duct. These are well protected by bony structures, so the chances of trauma are less in this area. However, in 7 to 15% of all facial trauma cases, these can occur, and they are generally involved with the naso-orbito-ethmoid fractures. If bony involvement is there in naso-ethmoid or bony NLD fracture, they are associated with these fractures in 29 to 68% cases. And if soft tissue involvement is there, then the medial canthal tendon area and the sac and canaliculus may also be involved. So how do you manage them? A facial CT scan is a must in such cases. It defines the presence or extent of the fractures. Direct injury to lacrimal sac and duct can also be explored. You can palpate it over the bones, and MCT attachment may demonstrate crepitus and clicks depending on the degree of instability. So always do the palpation over here. And the principles of repair should be followed, that it should be an early one-stage repair. Exposure of all fracture segments should be done. Precise anatomic rigid fixation should be tried. Immediate bone grafting if needed. Definitive soft tissue management. And generally, we require the need of ENT surgeons or surgeons, otherwise also plastic surgeons also sometimes, to go ahead collectively for these areas. Now, in cases of post-traumatic sac and NLD obstruction, if no obvious laceration is there in the sac and NLD, then do not explore it during primary surgery. Sometimes there can be just a temporary dysfunction and leading to epiphora or other symptoms, which is due to the post-traumatic edema, and it will resolve within a period of 6 months. However, permanent dysfunction may also be there due to detachment of the medial canthus, and so leading to subsequent compression of the lacrimal area, and pumping failure may be there. So how to manage that? Reassess at 3 months post-injury. CT and DCG provide helpful information. Silicone intubation, if easily possible, should be done. And subsequent DCR 6 months post-injury can be tried. Now, in post-traumatic cases, DCR techniques are a little difficult. Skin incision is somewhat kept lengthy than the routine cases. Avoid cutting the orbicularis muscle fibers to maintain the lacrimal pump function, which is already might have been compromised by injury. Bone drilling for bone removal, as bone can be thicker from inflammation and other impact from trauma, and nasal mucosa perforation should also be avoided. Silicone intubation is utilized in all cases because of the presumed predisposition to inflammation after trauma. Now, last, I would just cover the chemical injury to the lacrimal area. Chemical injuries can lead to immediate complications that can be punctal laceration, skin burns in sac area, or acute inflammation. Early changes can be canalicular stricture due to scarring of the canalicular epithelium or scarring of the skin over lacrimal sac area. Late can be punctal occlusion, canalicular strictures, lacrimal pump failure, and total obliteration of sac due to adhesions. Now, how to manage them? If it is a canalicular system trauma, wash thoroughly but avoid doing a syringing. Probing with bicanalicular intubation may be done. A conjunctival DCR may be required in some cases, and probing and pigtail intubations may also be done. NLD and sac trauma, if puncta is normal, probing with bicanalicular intubation can be tried. And if NLD block with total loss of puncta and severe canalicular stricture is there, then intracat DCR is the only option that we are left with. And so my take-home message to all of you is that suspicion and careful inspection are the keys to identification and repair. Repair should ideally be performed within 48 hours. That is the ideal situation. Magnification and illumination is essential, so better to go with that. Intubation of the canaliculus with a silicone stent to prevent stenosis as the laceration heals is also important. And early meticulous primary restoration of anatomy is the key to success. Thank you very much. And am I allowed to take this opportunity to convey to the students to kindly support me for member scientific committee election also? Thank you so much. With this, I'll end. I'll stop my sharing.
Thank you so much. Thank you so much, Urmil ma'am. It was a wonderful presentation. You really simplified the topic for us with good tips and videos. I personally like the fact that you're leaving the sutures untied pericanalicular, and that was very, very important tip for all the newbies in this field. I would like to invite the expert panel to give their comments now.
Yeah. So, am I audible?
Yes, ma'am.
Yeah,
Yes.
it's an excellent presentation, Urmil. You've consolidated the whole thing. It's not very easy in this given time. But from the point of postgraduates, I'd like to highlight a few things which is very important. First is identification of the tone canaliculus, the white ring sign. These are all typical examination questions. The white ring sign, where you will see the pearly white border, and then you will also see sometimes a pinkish hue is sitting on the orbicularis muscle, so you can easily identify that. In case you're not able to identify, then all those 3 tests that you do, the air bubble injection test, where you flood up the medial canthal area and you inject air, you'll see the air bubble. Excuse me. And then you can try, if not, you can try fluorescent dye test. And sometimes you can even use a bit of viscoelastic to, kind of dilate the lumen which is pouting out. So all these are helpful tips to identify the cut end of the canaliculus, if in case you're not able to easily identify. The next best thing is, I don't think it's an emergency. Even if you have a lid tear with a canalicular tear, this doesn't belong to the category of emergency management. You can easily allow it to go up to 48 hours, as was mentioned, and probably not beyond that, because then you will end up having an edematous lumen, which is not very good. So I think 48 hours is okay. And that's one thing. The other emphasis which I'd like to make is, if it's a simple tear, I think a monocanalicular stent is the ideal thing, which she beautifully showed. If it's a slightly complicated one, I think we should go in for a bicanalicular stenting, especially when the medial canthal tendon is torn. So medial canthal tendon tear definitely requires definite surgical management, because it's going to result in pump failure otherwise. So these are the tips that we need to keep in mind as postgraduates, because these are the common questions that will be asked in the exams as well. The rest of it was fantastic. Thank you, Orman, for doing that.
Thank you, ma'am. You very nicely emphasized the right points for the students. Thank you so much.
Yeah.
Thank you,
I
Dr.
congratulate Dr. Urmil for this comprehensive talk, very, very much
Thank you.
informative. And as Usha ma'am rightly pointed out, all the points for identifying the medial cut end. And I would like to add that putting 1 drop of adrenaline also helps in
Yeah,
blanching the
right.
tissue, like if it's messed up. And then under high magnification, you can very well beautifully see that ring sign. And most of the time, you don't need to go through the upper, canaliculus, and you can very well visualize it there. Other than that, one important cause that I want to highlight is the feeding associated canalicular trauma in the infants, that
Yeah.
all the postgraduates must know. If an infant present with this kind of history and having a lid tear, then always look for a canalicular involvement. So it can be very subtle, but if you have that history of, while feeding, the blouse hook was entangled and this trauma happened, then it almost always involves the canaliculus.
Yeah.
And the last point is that when you very beautifully showed the pericanalicular suturing, and always recheck after putting the sutures that during the manure, the tube may get
Sure.
kinked out. Sometimes it keeps coming out through the distal cut end. So always ensure that it is in right place before closing the surgery.
Yeah.
So that is one check.
Yeah. Thank you. Rightly said, Maya. Very rightly.
Thank you, Dr. Maya. Dr. Shahid, would you like to give any comments?
No, like I think Dr. Maya and Usha ma'am have summarized everything very nicely, so I don't have like any comments on that.
Thank
Yeah, and Dr.
thank
Urmil has summarized everything so beautifully.
Thank
It
you,
was
Dr.
nice.
Shahid.
Yeah,
Thank
quite a
you
nice
so
talk.
much.
Yeah.
And
Thank
one
you.
more thing, that the silicone rod that we use for ptosis, sometimes that also can be used
Yeah.
if you don't have mini monoca
Yeah,
stent.
and yes, definitely. These are all handy things, and according to the situation, we have to sometimes go in.
Yeah.
I understand. And especially in government colleges like ours, or even in SMS where you are, we really get the underprivileged patients, and sometimes they are really non-attended at all. So these are the things which we have to do handy in the OT to
Right.
take.
In that case, even a suture can be used. Just to
Yeah,
add.
exactly. Yes, ma'am.
Thank you, ma'am. Dr. Chawla, I had a question. You
Yeah.
said that you lift the medial most suture, the silk sutures that we're placing on the skin. Do you place it post-operatively? Do you hitch it
That's not,
somewhere?
yeah, that's not done always. But sometimes, if the injury is such that you feel that there's sagging down of the medial canthus, so that time you can definitely give a, like we give a frost suture in
Yes.
total surgery. Similar to that, we pull it anti-gravity and we can keep a taping up for at least a first few days. And then accordingly, you see it. And you, even for a week, you can keep, there is no harm. It helps definitely. If you've repaired the canalicular and still you feel that it is drooping, there's a medial, and primarily you cannot correct the medial ectropion or whatever problem at that stage is happening. So to prevent it from further enhancing, you can at least give that. Later on, if doesn't correct, you can do a secondary repair later on.
Sure, sure. Thank you, ma'am. That was a very useful tip. Thank you, everyone. Now we would move on to our next speaker, Dr. Shahid Alam from Shankar Nethralaya, Kolkata. So surgery is both an art and a science, and he will be taking us through the basics of eyelid reconstruction. So we will be able to appreciate the art once we know the science of it all. Over to you, Dr. Alam.
Just before Dr. Shai starts, Dr. Usha ma'am and Dr. Maya, and first I'm very thankful to all of you. You adjusted me for my talk. Right now I'm really tied up with some commitment. So I'm extremely sorry to say, ma'am, I shouldn't have gone, but I need to take leave and I will try to join again in between as soon as I get free. Thank you,
Thank you,
ma'am.
ma'am, for
I'm
being
very
here.
sorry. I'm feeling really bad, but I told Rolika really
Go
got
ahead,
it.
please go ahead. Yeah.
Thank you, ma'am.
That's okay, ma'am.
Okay.
Thank you so much.
Thank you, Rolika. Thank you.
Thank you, ma'am.
Okay.
Thank you, Dr. Chawla.
Thank you, Dhananya. Thank you so much.
Yes, Dr. Shahid, sir, we can start. Your screen is visible.
Yeah. Am I audible?
Yes, sir.
Okay. So, what happened?
So you can click on the screen and then it will start moving. So
What?
You
can
can click
click
on
on
the
the
screen, it will
screen.
start moving.
No, it's not.
It is in slideshow for us.
But I cannot see actually.
So
Just a
what
second.
is your screen showing?
Yeah. Okay. So,
Yes, it's moving
good
for
evening,
us.
everyone. So, I'll be talking on basics of eyelid reconstruction. So, I'll just share you with a case with you, like which had come to me a few weeks back after multiple attempts of eyelid reconstruction post tumor excision, and this patient had gone almost, I think, 6 surgeries. And as you see here, the lid looks more or less fine, but here you see there is lag of thalamus, there is corneal epithelial defect, and the patient complains of constant burning, irritation, watering, and lack of sleep because of it. So what are the primary problems here? So you see the primary problem, one is the lag of thalamus, but as you can see from the picture, cornea is not that much exposed. So the primary problem here is the skin. The skin is constantly rubbing over the cornea, and this skin, which looks normal from outside, actually its lining, its margin is, it's not lined by a mucosa, conjunctiva or something like a mucosa. That is a problem here. So with this background, I like to start my talk, and what are the points that we should keep in mind while reconstructing such a defect. I'll keep on stressing upon that. So the eyelid defects that we come come to us in our practice or can be broadly divided into neoplastic and non-neoplastic defects. So neoplastic defects are the planned regular outlines ones, which we generally do after a tumor excision, and the non-neoplastic defects are generally post-trauma. It can be a thermal injury, a chemical injury, or congenital defects like colobomas. So those sort of things. So whereas in a neoplastic defects, you have a clear-cut anatomy, you can have a distorted anatomy in non-neoplastic defects. And in neoplastic defects, since you are fashioning the defect, so you try to keep both the anterior and you have to uh, uh, excise whole of the tumor. So you excise both the anterior and posterior lamella, especially if it's involving both the lamellas. Whereas in non-neoplastic defects, most of the times, especially in cases of trauma, what we see that mostly it affects the anterior lamella only. So what are the principles for a neoplastic lead reconstruction? So we should have first of all a clear margin. We can debate about the primary versus delayed closure. The primary aim should be a complete tumor excision, and lead sharing procedures should be avoided in these cases because there's a risk of transfer of tumor cells if the margins are not clear to the other tissue, and rest is as any other reconstruction as we do for non-neoplastic. So these are the things that we should keep in mind whenever we are doing a neoplastic eyelid reconstruction. So this is a basic chart that all of the postgraduates should actually know whenever they have a question on eyelid reconstruction. So whenever we reconstruct the eyelid, so first of all we should know that the eyelid has a posterior lamella, an anterior lamella, and a posterior lamella. The anterior lamella is found by the skin and the orbicularis, and the posterior lamella is found by the conjunctiva. So you have to first of all know whether the anterior lamella is defective or the posterior lamella is defective, or both are defective. Now, depending upon that, you have to replace anterior lamella, posterior lamella. Now comes the size of the defect. So whether it is less than 25%, 25 to 50%, or 50 to 75%, or there is complete eyelid loss. So less than 25%, it can be done by a direct closure. 25 to 50%, in most of the cases, we do a tensile flap. We borrow tissue from the surrounding area. 50 to 75, lead sharing procedures, of course, if it is a non-neoplastic or you are sure about your margins or the tumor is small. And when there is a complete eyelid loss, so it's a complex procedure where you have to put a mucous membrane graft, and over that you have to put a flap for the anterior lamella. So this is in nutshell that about eyelid reconstruction and how you should go whenever you see a defect. I'll just give few of the examples, and I will go one by one from the simpler to more complex ones. So this is a defect which has been created after excision of the basal cell carcinoma. As we all know that the basal cell carcinoma is in most of the cases, it doesn't involve the conjunctiva and is limited to the skin. So here a 3 millimeter margin has been taken care of and the complete tumor has been excised, and this is a defect that has been created. So here you only need to replace the anterior lamella, and this is how the anterior lamella has been replaced. A graft has been placed, and rest of the thing has been closed by a direct closure. So what is full thickness skin graft? So it consists of epidermis and dermis, and the graft initially survives by plasmatic imbibition, which is later on replaced by fibrin. The vascularity actually starts after 2 to 3 days, and it takes almost a week to fully develop, and which is called as inosculation. And of course, it has a better survival in the periocular area because of the good vascularity. The graft should be fit to size, and we should avoid too tight a dressing because it will again produce vascular compromise. The area from where the graft should be taken, again, is a postgraduate question. It can be pre and retroauricular area, it can be supraclavicular and the medial arm and thigh. We should avoid the areas which are hairy. Now again, another example where only anterior lamella defect is there. This is again a BCC involving whole of the upper lid skin. So here the whole of the upper lid skin has to be excised. This is how the reconstruction has been done. So this is a freakish flap fashioned from the forehead where the forehead skin has been transferred to the upper lid, and this of course will need a division later on. What is a freakish flap? So freakish flap, so here it was originally described for lower eyelid defects where flap is taken from the forehead, is transferred to the lower eyelid, and later on it is divided. Actually, the freakish flap was first of all described by Horners for correction of cicatricial ectropion, from where the freakies got the idea of doing the eyelid reconstructions using this technique. So I'll just show you a small video of a freakish flap. So this is a morphiform basal cell carcinoma involving the lower eyelid, and we have excised the whole of this thing. And now this is the marking of the freakish flap here. Flap is raised. A tunnel is created through which the flap will be passed, and then it is anchored to the residual edge medially. Then conjunctiva is sutured to the lid margin to form a line, a mucosal lined margin. So now this is how it will look like. This is the second stage where you divide the flap. So the stump has to be completely excised, and then the areas will be closed and the canthus will be formed. So this is a nice flap for large lower eyelid defects and gives a nice cosmetic and functional outcome for this kind of a defect. Again, here we suture the conjunctiva. Now, trippier flap is another flap. It is basically a myocutaneous flap where the skin is taken from the skin and oblique is taken from the upper eyelid and is then transferred to the lower eyelid. It is also known as bucket handle flap, and it is used for lower eyelid defect. It was first of all described by T-Press in 1888. Now, some transposition flap. This is a small basal cell carcinoma. This is a defect created. I have created a Z, transposed the tissues. This is how it looks like on table, and this is, see, completely it has healed. The defect is completely, it's nicely reconstructed. So these are the few of the periocular flaps that you can use. We can use in our daily practice. This is a glabular flap. This is a freakish flap, and this is a nasolabial flap. This is the common flaps that we use in our daily practice. Now, coming to the full thickness defects, as I told that now we have to measure the size also. So if the size is small, we can go for direct closure with or without cantholysis, where you release the cantha, so which allows the lid to be mobilized. Here, a small tumor here, very small. This is a defect created. As you can see here, it has been nicely closed by a direct closure. A small video about the direct closure. So this is a sebaceous gland carcinoma of the upper eyelid. So this is a defect has been created. We assess for the tension in the tissue. I'm doing a canthotomy here. Now, a standard technique of lid reconstruction. The first suture passed from the gray line, then the mucocutaneous junction, then the eyebrow sutures are lash sutures are taken, lash line, and then the tarsal is sutured here, and after that the skin is sutured. And if there is any dog ear later on, so you can excise that dog ear, and that can be sutured later on. Thing that has to be kept in mind here, that the margin suture should be kept long so that they don't rub on the cornea, and then these sutures are later pulled up and buried in the skin sutures there. So this is the final result. Now coming to the Tenzel semicircular flap, it was described in 1975 by Tenzels, and it is a more or less a workhorse flap for most of our eyelid reconstructions, because most of our defect lies in the 25 to 50% category. It was originally described for lower eyelid, but a reverse Tenzel can also be done for the upper eyelid defect. So it is a semicircular musculocutaneous flap, and when we fashion this flap, we should keep in mind that this semicircle should not cross the eyebrow. I'm just showing an example here. This is a large lower eyelid. It's a procarcinoma. So this I have completely excised. This is a defect has been created. And this is a Tenzel flap with a small modification which I have done, which I will be showing in the video just now. And this is how the patient looks like at 3 months of follow-up. This is a simple Tenzel flap with a small modification. This is again a lower lid sebaceous gland carcinoma. The markings are done with 4 mm margin, and the tumor is completely excised. So once the tumor is completely excised, we measure the defect, and accordingly we raise the Tenzel's flap here. Yeah. So this is the markings for the Tenzel's flap. When we pull the flap, we see that there's tension while advancing this flap. So I do a small modification. I give a relaxing cut here so that this whole subunit becomes completely free from the flap and can be easily mobilized. So now this flap can now be easily mobilized, and this modification is especially helpful when the defect is more on the medial side. So this is on the lateral side, but when it is on the medial side, it becomes much more difficult to mobilize, and this small modification can help you. Now, rest of the suturing is by the standard technique. The flaps are closed. The wound is closed here. Again, here you have to keep in mind that on the lateral end, you have to suture the conjunctiva so that the margin is conjunctival lined. Now, coming to Cutler-Beard flap, it was described in 1955 by Cutler and Beard. It is now again for large upper eyelid defects, 25 to 75%. So it is a cutaneomyoconjunctival advancement flap. So you give an incision 1 to 2 mm below the lower lid tarsus and advance the whole segment, including the conjunctiva, the skin to the upper eyelid. In some cases, you can even separate the skin and the conjunctiva and then suture them separately into the defect. This is the original paper. It is quite interesting. When you read this paper, it was published in 1955 in American Journal of Ophthalmology, a method for partial and total upper eyelid reconstruction by Cutler and Beard. These are the diagrams that they have shown on table diagram. I don't have a video for that, but I have a picture of one of my patients. This is the defect here, where a beard flap has been placed. This is on table picture, and this is after defect. So see, the defect has been nicely covered up. Now, Hughes trasoconjunctival flap is the similar thing when you do it for the lower eyelid. So it was again described by Wendell Hughes way back in 1937, and you give the incision 4 millimeter of lid margin so that the upper lid is stable and you have at least 4 millimeter of tarsus in the upper eyelid, and the flap is sutured to the lower lid defect, conjunctiva sutured, and over that either you can put a graft or you can just advance the cheek skin over that. Again, this is divided after 4 to 6 weeks. So this is the original paper where Hughes published it as a case report for reconstruction of the lower eyelid. So this is the lower eyelid sebaceous gland carcinoma, and this is the lower eyelid defect. So I'll just showing the video here. Yeah, so this is a large lower eyelid sebaceous gland carcinoma, and almost whole of the conjunctiva has to be sacrificed, leaving just a frill of bulbar conjunctiva there, as you can see, and it's a large lower eyelid defect. So now I'm just giving cryo to the residual margins. Now the upper lid is everted, 4 mm marking is done, and then the conjunctival flap is raised. Is it visible nicely?
Yes, Dr. Shahid, sir.
Yeah.
It's
okay. So now this flap is then sutured to the residual conjunctiva that was there in the lower eyelid, the continuous absorbable sutures here, and over this I'll just advance the cheek skin because she's an old lady and we have a lot of lax skin there, so I can just advance the skin. So here, yeah, and this is how I just passed a forceps and see that yeah, it's free from both the end. And then after 4 to 6 weeks you do a flap division. So you pass. I generally I pass artery forceps just to guard the ocular surface. And here what you have to be careful that you leave the conjunctival edges a bit longer so that it overrides the skin, so that you are sure that the margins are completely lined by the conjunctiva. Now this is the last case which I am showing here. This is a large sebaceous gland carcinoma, and as you can see here, there's a complete eyelid loss. Nothing is there, no conjunctiva, no eyelid skin. So this has been reconstructed. I said these cases are quite complex, where there's a total eyelid defect. So here I have raised a glabellar flap, and this glabellar flap is lined by the conjunctiva, and that conjunctiva is now sutured to the bulbar conjunctiva, residual bulbar conjunctiva there. So to conclude, in cases of tumors, a complete tumor excision with wide free margin is the primary aim, and create a mental picture of the defect and have a tentative plan ready beforehand. Upper lid defects are more or less functional, while lower lid defects are cosmetic. In many cases, you can just leave the lower lid defects like that, and they will heal by itself. It's called laissez-faire. An anterior lamella, posterior lamella, and a lid margin with a mucosal lining. So these are the 3 things that you should keep in mind whenever you are doing a eyelid reconstruction. Thank you. So can I start with the quiz here?
Sure, Dr. Shahid, that was a wonderful presentation. You can start with the quiz. I'm looking at the YouTube participants. So for all our participants, Dr. Shahid here has wonderfully taught us eyelid reconstruction, all kinds of and all sizes of defects he has covered. And he is conducting a small quiz here that will be on your screen soon. And we will wait for 10 to 15 seconds extra as our participants can answer on YouTube and to factor in that lag here.
Should I close this thing?
You can show it as a slide presentation, or you have something where they can scan a code, or you can show it in the slides
No,
as
just
well.
it's a PPT.
Sure, you can share that PPT.
Yeah.
Yes, sir.
I stopped sharing, no?
You have stopped sharing, sir. You can share the second.
Okay, it's a very small quiz, just 10 questions. Sorry, I have a bad viral. Is it visible?
Yes, it is visible for us, sir.
Can I start?
Yes, you can start, sir. I'm
Okay.
unable to tell how many of them are watching, but
Okay, no problem.
I'm looking at YouTube.
At 4 or 5 of us are there, so we can answer amongst ourselves. So the first question is, which of the following options is not suitable for full thickness eyelid reconstruction? Direct closure, one graft, one flap, two flaps, two grafts. So I'll wait for 10 seconds.
Yes, Dr.
Which of the following options is not suitable for full thickness lid reconstruction? Direct closure, one graft, one flap, two flaps, two grafts. So any answers, Ananya? You have got any answers?
We don't have any answers on YouTube, but we have Dr. Meenakshi in the chat. She says D is your answer. That's
Okay. 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 So Dr. Meenakshi, the answer is correct. We don't use two grafts because grafts lack their own blood supply, and using both two grafts, will be risky. They won't survive. So good. So I'll go to the next question. In 1955, by N.L. Cutler and C. Beard, they described a two-stage advancement flap for full thickness upper lid defect, posterior lamellar upper lid defect, full thickness lower lid defect, or posterior lamellar lower lid defect. I'll wait for 10 seconds, Ananya.
Yes, sir. We don't have any answers here. Any takers from the faculty chat here? Everyone is one. It's just a fun quiz.
Yeah, it's just a fun quiz. I also can answer.
So no answers on YouTube. I'll take this. I think he described
Ananya, please.
for a full thickness upper eyelid defect.
Yeah, so it was described for the full thickness upper lid defect. It's a two-stage procedure which I had already shown. So where for the full thickness upper lid defect, you take a tarsoconjunctival flap, and over that either a graft or a advancement flap. The next question. In Hughes tarsoconjunctival flap, the leading edge of the flap is deliberately placed at a shorter distance above eyelid margin. What is the recommended distance for this? 2 mm, 3 mm, 4 mm, 6 mm. This is for Hughes. That is, you are reconstructing the lower eyelid. So you are taking the tarsoconjunctival flap from the upper eyelid. So you have to leave a margin of how much of the tissue? 2 millimeter, 3 millimeter, 4 millimeter, or 6 millimeter?
We can go ahead with anyone who would want to volunteer.
Yeah. Rolika, you can volunteer.
Dr. Maya says 4 millimeters.
Sure, sir.
Dr. Maya says 4 millimeter.
Yes, sir.
Okay, Dr. Maya is absolutely correct. And yeah, we should maintain a 4 millimeter tarsal strip, as I discussed in my this thing class also. It is to preserve the eyelid stability.
Yeah.
Now, all of the below eyelid reconstructions are two-stage procedure except Hughes tarsoconjunctival flap, Ficky's flap, Cutler-Beard flap, or a tensile semicircular flap. So which of the following is not a two-stage procedure?
Roleka says tensile semicircular flap, sir. And
Yeah,
Dr.
tensile semicircular flap. Rest all are the need division.
Two-stage.
This is a diagrammatic representation of all the flaps.
Yes.
Now, Tenzel's musculocutaneous flap is a type of rotational flap, advancement flap, sliding flap, transposition flap. Is it a rotational flap or an advancement flap or a sliding flap or a transposition flap? Any idea, Rolika?
No answers in the live chat, sir. Anyone who would like to take this up? We have some answers here, but it's no, it's for the previous question. Probably because
Previous questions.
Yeah, for question 2.
Oh, I think it's quite delayed there then.
Yeah.
Am I audible now?
Yes.
Rolika, yeah.
Yes, sir. It's an advancement flap. Sorry,
Yeah,
my
Rolika,
network.
it's correct. It's an advancement flap. So the various flaps which can be used, they are broadly divided into 5 types: sliding flap, advancement flap, rotation flap, transposition, and island flaps.
Jasia Oftam has also answered here, and she said A. So thank you for answering, but you need to mention the question number as well. Thank you.
Yeah. Identify the flap shown in picture. Trippier flap, Fricke's flap, McGregor flap, Glebler flap.
We have Dr. Abhijit Jain answering as A, the Trippier flap.
Okay. Anybody else?
We have Dr. Meenakshi answering as B, Fricke's flap.
Okay. So Dr. Meenakshi is correct. It's a Fricke's flap. This picture I had already shown in my talk. It's a Fricke's flap where you do a lower eyelid reconstruction from the forehead flap. This is the clinical picture. A 36-year-old male patient has significant lag of ophthalmos with corneal exposure, firecracker injury as shown in the picture. Which of the following is a suitable option for this patient? As you can clearly see here, this is a primary gaze picture and this is on lid closures. You see, almost whole of the cornea is exposed. So you have to do a lid reconstruction here. So which is the suitable option? Hughes flap, mucous membrane graft, full thickness skin graft, mucopericordium free flap. The conjunctiva is healthy. I'm just giving a clue. Although it looks from the picture also, if the conjunctiva were not healthy, there would have been signs on the cornea here. But yeah, exposure keratopathy is there. So lag of ophthalmos with corneal exposure, post firecracker injury. You can see here, and anterior lamellar shortening. You can see in the diagram. So what is a suitable option?
Yes, we have Dr. Maya saying full thickness skin graft.
Yeah. So full thickness skin graft is the correct answer for this thing because there is just anterior lamellar shortening. So now this is a Tenzel's flap with modification, where a Z has been introduced in the Tenzel's flap. So what is this modification called? Temporal advancement flap, Mustardi's modification, McGregor flap, or Trippier flap?
We have Dr. Maya Hada saying C.
Yeah, Dr. Maya is absolutely correct. It's a McGregor flap. This was a modification introduced to release the tension. So as I do on the lower side, they do in the upper side. Z in the form of a Z. It's a McGregor flap. Z at the end of Tenzel flap. So 9th question: which eyelid reconstruction technique is distinctive in transferring a lash-bearing margin to the defect? So whatever we do, the Cutler beard or Hughes, you cannot transfer the eyelash.
Yes.
Posterior auricular, you mean graft?
Yeah. Free flap.
Free flap.
Yeah. Post auricular. Free flap in these cases, sir.
She means graft only.
You mean graft?
Yeah, graft.
I
It's a free
personally
flap
don't have
graft.
any
Yeah.
experience with free flaps.
Right, sir. Okay, sir.
No.
So you don't
I don't
prefer
have,
the free
yeah,
flaps?
I don't.
Okay,
No.
sure, sir.
Like till now, like I haven't had the need of a free flap.
Okay, sir.
Because see, in a free flap, what you have to do, you have to get the two ends of the vessels, and then both the vessels you have to anastomose. Then only the free flap is going to survive.
Sure.
So with
Right.
our training of oculoplasty, so that is, too much of an expectation. I have done a free flap for a contracted socket. So that was a radial artery based free flap which I had done, but that again with the help of a plastic surgeon.
Right, sir. Thank
Yeah.
you. Thank you for answering that, sir.
Yeah.
Over to Anna.
Now,
So,
would you like to- yes, Dr. Kim.
okay, so no, just reminding that we are dealing with postgraduates and our
Yeah,
emphasis is more towards basics
yes,
of
ma'am.
eyelid reconstruction. I think Shahid has done an excellent job of highlighting the most important points and also answering a few critical and complex situations as well. Just to sum up whatever Shahid has mentioned, I think just a few reminders for the postgraduates. One, we have the septum dividing the entire eyelid into two functional aspects, the anterior and the posterior lamella. So the one important point that must be kept in mind is at least one of the lamellae should have the blood supply. So that's very important as a principle. And then you should, as postgraduates, you should know what anterior lamella is, what posterior lamella is. And the rule of the thumb, as was being discussed, is never put one graft over another. You can use a flap for one layer and you can use a graft for another. That could answer some of the questions which were raised during the discussion. So you must know what anterior lamella is, what posterior lamella is. Anterior lamella is just skin and orbicularis, and posterior lamella is tarsal plate and conjunctiva. And when you're using reconstructive procedures, no graft over graft. One can be a flap and the other can be a graft. And as was rightly pointed out, he showed the algorithm very clearly. So to less than 25%, I'm sure we can all do with a direct closure. And I think as postgraduates or as general ophthalmologists also, you would require to know the principles, which was very well highlighted. Beyond 25% to probably even up to 75%, I think we can use the we can use up to 25 to 50%. I think with a lateral cantholysis, we can actually try to do a direct closure. When it goes beyond 50 to 75%, probably the Tensil's semicircular flap for both upper and lower lid would be helpful. Beyond 75%, I think you can go for a Cutler beer for the upper lid and the Hughes flap for the lower lid. I think this has been very well highlighted with all his videos as well. So this is something that we need to keep in mind as postgraduates. These are the common questions that will be asked. I think it's important for us to understand that. And again, as we were doing the direct closure, as he pointed out, first address the gray line and then we need to suture. And remember, whatever sutures are applied internally has to be absorbable sutures, and whatever is external can be non-absorbable suture. And it's important for us to manage the tension. The tension should always be horizontal, never vertical. That's important. And of course, like was mentioned for the grafts, it should be like to like. You need to, you can use the skin from the upper lid for the lower lid, and you can use pre-auricular sometimes for very small defects. I've tried and it's quite successful because it's a color match. And then you can use post-auricular, supraclavicular, upper inner arm. All of these are fine for grafts. And of course, for posterior lamella, I think it was clearly mentioned, you can use the tarsal plate, like you can share a part of the tarsal plate. You can use hard palate. You can use the ear cartilage. Only thing is you have to be conscious of the way you position the ear cartilage. You can have a little bit of a distortion with the ear cartilage, but the hard palate is very good replacement. And often when we are reconstructing, I think it was highlighted a bit, we need to remember the lacrimal system as well. Never to forget reconstructing the lacrimal system. So these are some of the points I thought would be important for the postgraduates.
Thank you so much, ma'am. I think you have highlighted the points, and I think that's what I was trying to mention when you mentioned the cartilaginous part. When we take the post-auricular graft, or like as we call it, the free flap in general, when we take that, the cartilage kind of replaces the tarsus. So that's a very good replacement for the lower eyelid and the lower eyelid preferably. That's what I was trying to emphasize. That's thank you so much, mom, for sharing that. And Maya, ma'am, may we request you for your inputs as well.
Yeah, very nice talk, Dr. Shahid. And I think you and Dr. Usha has summarized almost everything. Just one point that I want to highlight is that while doing the glabular flap or the Freaky's flap, do you also do a separate posterior lamellar reconstruction? Because the case that you have shown in the end, the large upper lid sebaceous gland carcinoma, you have done a median forehead or a glabular flap. So have you done any sort of posterior lamellar?
Yeah, I mean, it was lined by a mucous membrane graft.
Right. So it is
Yeah.
important that you, for the all postgraduates, that you recreate both the lamellas wherever you are reconstructing. Otherwise, the flap will be, it will be adhered to the underlying conjunctiva. There will be symblepharon. You cannot just put a anterior lamellar flap over the conjunctiva. So it's very important. And other thing is that whenever you are doing the tensors, it's important to fix the lateral canthus, and the fixation suture should be a little higher than what you expect is a normal anatomical position, and because it tends to droop down a little bit. And all the other cases and the techniques were very well, beautifully summarized by Dr. Shahid. Congratulations for that.
Right. Thank you for adding that point, ma'am. Actually, very rightly commented that the anterior lamella and posterior lamella has to be addressed separately. In fact, a lot of plastic surgeons also forget about it, and because we focus so much on the lid anatomy that we keep that in mind. But I've noticed that the plastic surgeons also don't have that in mind, and they have to keep the posterior lamella separate, and it has to be a separate conjunctival layer, or it has to be layered with a mucous membrane or an amniotic membrane graft.
So the first
So
photograph that
thank you
Dr.
for that.
Shahid has shown, I think it was done
Yes.
by somebody in other country.
Yeah, I had shown that photograph for that purpose only. So it
Yeah,
was
Right.
repaired by a plastic surgeon only. 4 surgeries were done, and
Yeah.
the lid was rubbing over the cornea, the skin.
Yeah, the keratinized skin was,
Keratinized, yeah.
in the cornea. Yes.
The lid margin was not lined by
Mucus.
a mucosa.
Right. Thank you for highlighting that. Ananda, do we have any questions that you would like to address?
We don't have any questions on YouTube. We do have good participation for the quiz, though.
Right. Okay, so Ananda, we can go to the next talk, not a problem.
Thank you so much, Dr. Shahid and the panelists.
Yeah, thanks a lot.
Moving on, we will go to Dr. Meenakshi Wadhwani from Guru Nanak Eye Center, New Delhi. We will learn ptosis surgery from the expert here, and she will be talking about management of congenital and acquired ptosis. Over to you, ma'am. Ma'am, you could share your screen and unmute yourself. Yes, ma'am, your screen is visible. It's not in slideshare mode yet.
Is it now in the slideshare mode?
No, ma'am.
No, but like I have put it at my site, it is visible.
Could you stop the slideshare mode, share it, and then put it in slideshare mode again?
Stop share and then again.
And first share your screen from Zoom. And then in the top left corner, you will have play from start. Yes, it is in slideshare mode now. It is on the slide that says ptosis. Yes, wonderful. It's on the first page. Thank you, ma'am.
Thank you so much. Thanks to all of you and especially to AIS for giving me this opportunity to present this topic. It's on management of congenital and acquired ptosis. So basically, I'll be just going on a few slides on the only on a anatomy. Rest I'll be detailing about the management. So ptosis is, as all of us know, drooping of upper lid more than normal. Generally, the lid covers upper 1/6 of cornea, and the main muscles involved for the upper lid movement are levator palpebris superioris, and a little bit by frontalis muscle also. Now going on to the classification directly, doses can be classified into congenital and acquired. And for the acquired ones, it is further classified into mechanical, aponeurotic, neurogenic, and myogenic. So for any case of ptosis, the aim is to know about the type of ptosis, degree of ptosis, whether it is simple, complicated, or it's by the and why do we have to intervene is because of amblyopia in children, especially in the cases of congenital ptosis and other associated conditions. Further detailed classification, which all of us should know in the case of, especially in the case of congenital ptosis, is whether it's a simple ptosis or it's associated with complicated few things like blepharophimosis syndrome, superior rectus weakness, or Marcus Gunn jaw winking phenomena. And acquired, I've already mentioned. And like before going into any case of ptosis, we should take a detailed history in the form of time of onset, whether it is unilateral, bilateral, increasing or decreasing, or constant with time. There is any family history, especially in some syndromic associations like in the blepharophimosis. Jaw movements like in Marcus Gunn jaw winking phenomena, abnormal ocular movements, abnormal head posture to rule out MAD.
Okay,
And
Meenakshi, if I can interrupt.
yeah.
Your voice is coming from a distance.
I didn't get
Previously, it was fine. Since the last slide, your voice is coming from a distance. If you could readjust your mic or stay closer.
Is it now fine?
Yes, this is fine.
Thank you for correcting. So now for next is that before going after taking history, we have to go to ocular examination, which is the most important part of any case of ptosis. And the main thing, especially in the case of congenital ptosis, is corrected and uncorrected. That is best corrected visual acuity after refraction plays an important role, followed by any head posture, palpebral fissure height, especially vertical, palpebral aperture in primary gaze, up gaze, down gaze, and palpebral aperture horizontal, and presence and degree of ptosis, levator function, lid crease, and presence of some mass, dermatochalasis, frontalis overaction, Bell's phenomena, which is the very important point for dealing any case with ptosis, ocular movement, and other associated signs. So vertical palpebral fissure height is generally important. Basically, for any case of ptosis, we have to measure the MRD1, which is the marginal reflex distance 1, which is generally done from the pupillary reflex to the upper lid margin. And then is the vertical palpebral fissure height, which is compared, which has to be calculated in all the three gazes. And in the case of unilateral ptosis, it is compared with the other eye, and in bilateral, it is generally done in the form of mild, moderate, severe. That is, mild is up till 2, 3, moderate is up to 3 millimeter, and 4 millimeter is the severe one. Then is this small video which is showing that why before any going into case of ptosis, we have to see whether it is a unilateral case, bilateral case. Here the person is, the PG is measuring the MRD1 by asking the patient to see in the primary gaze. And the next thing, which the right eye is the affected eye, more severe ptosis. And now he's blocking the frontalis to measure this thing LPS action, which I wanted to show in this video, basically. And the patient is asked to look in the upward direction. And along with that, whether it is acute, chronic, progressive, or associated with some other conditions. Next comes this very important thing, which is the Bell's phenomena. Generally, in very small children, less than 1 year infant, it is very difficult to measure. So in that case, we ask the parents to take the picture in deep sleep when the child is sleeping to look for the uprolling of the cornea. Otherwise, it is defined as Bell's, as all of us know. Good is when the less than 1/3 of the cornea is visible, and poor when more than 1/3 of the cornea is visible, and normal is up and out as seen in this slide, and inverse is up and in, and reverse is down and out. So for managing any case of ptosis, what are the various steps we have to see is what is the indication, contraindication, timing, because in children generally we don't just rush and do the surgery. We have to go look at the age, and then we all should know relevant anatomy of the lid, type and choice of surgery, and preoperative details as dealt previously. So the main aim of surgery is to maintenance of corrective lid position, that is to avoid obliteration of visual axis, especially in the congenital ptosis, to prevent amblyopia, preservation of normal lid crease, and maintenance of normal tear film. So main treatment is surgical most of the times, but we have, after taking the history that I have mentioned previously, cosmesis concern in the adults, and which procedure is to be done is depends on the levator function plus associated anomaly. And like in the cases of squint, with the ptosis, squint has to be dealt first. Similarly, in the cases of blepharophimosis, firstly the surgery has to be done for the horizontal thing, that is telecanthus, and then the vertical component is dealt with. And yes, of course, in the cases of amblyopia, we have to do an early surgery. Now moving on to the main management of congenital ptosis, which is the tarsofrontalis sling. After doing the refraction of the child, and when we feel that the child can become embryogenic, especially in the case of severe ptosis, the main criteria for this is that levator action should be less than, if it is less than 4 millimeter, and Bell's is good, of course, then we proceed on with this surgery. There were two important techniques, though there are many techniques, but generally which I would like to mention is Crawford double triangle and Fox pentagon. And most of the time in this, we follow this Fox pentagon because it is sling surgery is preferable, as all of us we know that it is a small skin incision is done. It is reversible. It takes less surgical time, and obviously sling is easily available. And like in this, it is very important to know the 5 points which have to be known to us. First is that the 2 points should be parallel on this tarsus. They should be 6 millimeter apart. Then 2 points parallel to the medial and lateral canthus, and 1 point should be on this parallel to the pupillary reflex, just on the above the eyebrow, and 1.1 centimeter above. So the sling has to pass. We generally use the sling with the sleeve, which generally through the it's a silicone sling. And then after making this point, it is very important to make this superior pocket, prefrontalis pocket, especially in the superior direction. It has to be done in the starting of surgery only, before putting the sling, because ultimately the sleeve has to be buried into this, and burying of the sleeve is the most important thing, because otherwise it can lead to further complications, as I will show. This is a picture which is showing the 3 important points and how this sling has to pass through this pretarsal area, and then the burying of the knot. These are the important thing. And yes, in the children, it is very important to give a reverse frost at the end of surgery. It's a video, but here it's a detailed video, it's a very common surgery, so I will not go to the video. I've just highlighted the important points. So next, going on is to the what are the why, though in the cases of the contraindication is the poor Bell's. In that we can do if it is a severe ptosis, but with the undercorrection as done in this child. And sometimes it can lead to some complications, like this is the extrusion which I was telling. Here there was a granuloma formation first, and then the sling is extruded out. And a few disadvantages of sling are like lid lag, as seen in this child. He's a corrected case of severe ptosis, but after correction he has developed, this is a normal thing which we have to tell to parents, that the child will have lid lag and lag of thalamus also, which will subside with time, but it will take few months. But lid lag will not go completely. Plus, sometimes a child can develop notching and furrowing of the burrow also, as seen here. So all this has to be taken in consent and told to the parents before the surgery only. Then this is a congenital ptosis only. That was a simple congenital ptosis. Now is if it is associated with some syndromic associations, Like in the case of BPES, which is also called the blepharophimosis ptosis epicanthus inversus syndrome. So in this case, it is not generally the patients approach to us with this telecanthus and they are worried they have severe ptosis. But if a child is small, we can first go for the refraction, because generally these children are not very amblyopic, because they have from the childhood they develop a habit of chin raising. So we don't have to jump and do in the very small children. We can wait and watch. And after that, we have to do first the horizontal correction surgery, which is telecanthus, which can be done either by Verway's VY-plasty or CU-plasty. And after 3 months of that, we can correct the ptosis by using silicone sling. I generally use silicone sling. I have never used fascia lata for this, though many people say fascia lata, but because of two side surgery, I prefer this. And the main thing is that it's a better result. He's a corrected case, though he's not very much satisfied. He has underwent this CU-plasty, and the ptosis surgery has not been done in this. So these are the markings which are generally taken in the case of this VV-plasty. Like this is the desired place for this for the first the telecanthus correction has to be done, and the medial palpebral ligament, it has to be exposed, and then it is brought near to the the similar incision is given like in the DCR surgery, and then it is hanged over to the anterior acromial crest with the non-absorbable suture. And then after the second stage, we can correct it with the silicone sling. So generally the second stage is preferred minimum after 3 to 4 months of the first surgery. So, and then this is another important complication of congenital ptosis is Marcus-Gunn jaw winking phenomena, which is one of the which is because of the congenital aberrant connection between the branches of trigeminal nerve and muscles of mastication and the superior division of oculomotor nerve. So this is a slide which is showing how this patient has synkinesis. Like when he's opening the mouth, there is a clear movement of the upper lid in the left eye. And then when in this type of case, we have to do there are three grades for this Marcus-Gunn jaw winking phenomena, whether we have to intervene or not. Mild is when there is less than 2 millimeter of synkinesis, and severe is more than 5 millimeter, as seen in this gentleman. So he underwent LPS excision along with the sling surgery in this eye. See, so this is the after the sling surgery, and we have to tell them that Marcus-Gunn jaw winking phenomena might not go completely, but yes, most of the times it is preferable to do bilateral sling surgery in these cases. And here in this video, I just wanted to show that it would be better if we take if we take while doing this LPS excision in these cases. I will tell in the detail of how LPS resection is done in that side. So while doing that, putting the sling, it is better that after excising the LPS completely, we take the sling from inside like in the previous sling, we have done from the skin approach only. In this case, it is better to go from the inner side through the tarsus. So to have a better lift in these cases. This is also another person with this. So now coming on to neurogenic ptosis, the congenital ptosis is done. Now coming on to acquired ptosis, another aspect is neurogenic ptosis, but it can be associated with third nerve and other associated syndrome. And like in this girl, she has a third nerve, the sixth nerve palsy. And in case of third nerve palsy, if the Bell's phenomena is absent, so we can correct the squint, but ptosis cannot be done. So in these cases, we advise crutch classes. In this girl, we have advised, she was already wearing crutch from somewhere else she was advised, and she was a very compliant patient. She is wearing this crutch. This is a conventional crutch. And similarly, but this crutch has a disadvantage of less of blinking. So this is a new crutch glass which I have invented with someone recently. We got a patent also. So in this, the main advantage is that it has some spring-like action, and because of this spring-like action, which is compressible, the blink rate of the patient is not affected. So that is why this is a newer modification in the crutch. And I have been advising this to many of my patients with neurogenic ptosis, and they are wearing it. So next comes is aponeurotic ptosis. So it can be congenital, it can be acquired in the case of like in the trauma or with the age. And here the ptosis will be constant in all the positions of gaze, and it will the patient generally have good levator function. And is as seen in this slide, a thin transparent lid is seen in these cases. And the LPS sometimes while doing in the, especially in the involutional cases, LPS can be thin also in the intraoperative thing. So this is another algorithm which is showing half of this thing is done. Like if the levator action function is less than 4 millimeter, we generally go for tarsofrontalis link. But if it is more than 4 millimeter, and then we go for levator resection or plication. And when it is less than, but if it is more than 10 millimeter, but the ptosis, degree of ptosis is less, then that is less than 2 millimeter, then after doing the phenylephrine test, we can go for Fasanella Servet approach also. So now is the thing which is very important, surgery for ptosis, especially done in the case of acquired aponeurotic cases, or sometimes in the congenital cases also if the levator and function is good. So this is the Beard's evaluation. According to this, the levator function is categorized into less than 5 millimeter. If this is the degree of ptosis and this is the levator function, and this is a algorithm which can be followed for the resection of this thing. If the levator function is less than 5 millimeter, then we can go for maximum. But generally, for the good levator function, a smaller resection can also help in the case if the degree of ptosis is less. So this is a slide which is showing that in the case of levator resection, how it is important that we have to make some these two important markings at the medial and lateral pupillary limbus, and then central pupillary margin. And this is a lid crease mark, which is very important. And after giving the it is always better that we don't give block in this lid area, and we give this before giving the block, this mark should be made. And otherwise because of the swelling or localized this thing, this is slightly after it can lead to some other type of results. So in order to approach it correctly, it's better to give it before giving the block. In the females, it is given at a height of around 8 to 9 millimeter, and in males, it is generally given at 7 millimeters. And it's better if a patient has unilateral ptosis, we compare the lid crease of the other eye, and then we mark it. And here is another screenshot which is showing that after giving this thing, if we are using RF radio frequency cautery or a blade, then this is the orbicularis muscle, and then we have to go slowly and do the dissection. For this, we should be very much well versed with the levator anatomy, LPS anatomy. We have to go down near the tarsus and then up towards this thing below the orbicularis, and when we reach the orbital septum, it's like we find the pre-aponeurotic fat pad, and then we put it in this. I have shown the surgical steps that how it is done. And in the end, in this slide, I've tried to show that it is very important to give three important markings after this is the levator which has been identified finally, this white sheath. So we have to take final, we can take a non-absorbable suture in the form of proline, 40-proline, or otherwise we can take absorbable suture, either vicryl, and it has to be passed from tarsus and then it has to be taken out. Three such sutures are very important. One from the, as I have explained previously, from the pupillary margin, and then from the medial and lateral limbus. Medial and lateral, and it is very important to cut the medial and lateral horns also of the LPS to get a better post-operative correction. And yes, we have to avert the lid in between to see if we don't go full thickness. These are few results. In all these cases, I generally give this reverse frost suture, so that the patient doesn't develop this exposure keratopathy. She is a case of LPS resection. She has also she is a case of, basically she was operated somewhere else, so she has underwent re-resection in our hospital. He is a case of congenital ptosis with good levator function. So he underwent with severe ptosis. So he underwent this thing in both the eyes. I have done around 20 millimeter of LPS resection, but now he has landed up with this complication of this in left eye. He has this extra amount of skin, which ideally should have been resected. So now I am planning to do a blepharoplasty in as a second surgery. So all the surgeries, they are not happy always. We have to be prepared for some complication. And similarly, I would like to say in the end that uh, not only this, that we have to make lid crease sutures also in the end. After putting these tarsal sutures, lid crease sutures are also important. So they are put with the vicryl, and that at that time we have to take the from the orbicularis. Then we have to take that after resecting the stump of that, from that resected stump, that vicryl has to pass, and then again from the orbicularis, and then finally we have to close the skin. So that is an important thing. So after going from LPS resection, next comes is myogenic ptosis, which is very important part of ptosis, but here we don't do generally any surgery. Like he's a man, he was so much having so problem. So he came to my OPD with this type of the taping on his eyelids. He's a case of total ophthalmoplegia, and I advised him crutch. We in fact gave him crutch, but he's not a very compliant patient, that he said that I want a corrective surgery. So now finally he will be corrected, because his levator is this Bell's is also very poor. So if he will be corrected, so he will be corrected in a form of only up till the limbus. A proper under correction only under correction can be the solution for his surgical thing. Otherwise he has to wear this prop surgical crutch glasses. So in this myogenic ptosis, generally we have to rule out myasthenia gravis. We have to ask the patient regarding the variability of muscle weakness. We have to do few tests also, which I can't cover up in this, like ice pack test. And then after 5 minutes of that, whether there is 2 millimeter of improvement. Eyelid peak sign is also there, when after closure there is for 5 minutes there is a sudden peeping of the patient peeks through peeks through the sclera is visible. Similarly, another important test for myasthenia is after ice pack test is we can go for a neostigmine test, but we generally don't do we refer to the medicine department, neurology, for ruling out myasthenia if a patient is positive for any of ice pack test, or eye peeking sign, or Kogan-Litwitz sign is there. So then after this, a few people also advocate giving pyridostigmine and oral steroids also for the correction of myogenic ptosis. But we generally refer the patient to the medicine people so that they can further intervene. So now this is a case of mechanical ptosis. Here it can be due to eyelid tumors, as seen in this child of neurofibromatosis. So in this case, it's not important to rush, because for any surgery, especially till the child is grown up, okay, we know he has cafe au lait spots and leash nodules in the iris, but like because the visual axis is not covered, so we can leave the child and we can go for we can wait further, and we can, yes, definitely do the refraction. Similarly, in this child, he has tarsal cyst. So in this man, he is tarsal cyst. He underwent excision, and he's better now. So mechanical ptosis also can be covered up by removing the cause of ptosis, like in this case of, especially in the eyelid tumors, which require excision, cicatricial conditions, which may require graft, and traumatic also, where we have to generally explore the eye. So in the follow-up in my last 2 slides, I would just say that it's not important just to do the surgery. Follow-up is the main important step. We have to take a proper consent. We have to tell the patient that always the correction is not similar to the other eye. In case of unilateral ptosis, they have to be prepared for another surgery, especially in case of sling, they might need revision of sling. And in post-operative period, especially in case of LPS resection, sutures have to be removed after 8 to 10 days. And if lag of thalamus is severe, we have to tell along with the lubricating agents that eyelid has to be taped at the time of sleeping. And once the repair is stable, patients can be followed up at every 1 month. Disadvantages of these surgeries, as previously explained, is that corneal exposure, eyelid can be too high or low. And if then, especially in LPS resection, if there is undercorrection, we have to wait for another 6 months and then further correct it as a new case after 6 months, preferably. And if conjunctival prolapse is there, it can be due to the, I have seen one conjunctival prolapse in LPS resection. Previously, I have treated her now, and thankfully she got corrected. I just put Simplifron ring in them and have padded the eye for around 2-3 hours. But otherwise, if it would not have improved, then another thing is that we can take this phonics forming suture types of suture and reposit back the pan type of suture which is said if it doesn't get reposited for 6 weeks. So thank you and my acknowledgement to all my seniors of oculoplasty whom I sometimes disturb for taking the advices, precious guidance, my senior residents, my postgraduate students and my unit head. And thank you to AIS for giving me this precious opportunity. Thank you.
Thank you so much, Dr. Meenakshi. You made all the ptosis seem so easy and the surgery seem so easy. They were so beautifully done, so flawlessly done. Thank you so much, Dr. Meenakshi. I have a small question for you. From PG point of view, when you assess a patient with Marcus gun jaw winking ptosis, and on table when you have to decide where to keep the lid height, is there a particular jaw position that you ask the patient to keep in, or how do you decide where to leave the eyelid?
No, generally, if the patient is undergoing, I compare it with the other eye only. And if like in the previous 2-3 patients I have done for Marcus gun jaw winking phenomena, I generally keep it 1 millimeter or at the limbus only, not more than that, because obviously and generally because in these cases LPS has been excised, so we have to do it in the form of sling surgery. If we are doing a bilateral sling, it has to be kept at the limbus as we do in the other sling surgeries. And if the panel has to give me some other precious guidance, then I would be happy to know.
I would also like to extend this question to the panel, that is there a jaw position in which we ask the patient to be, or how do we judge?
The whole issue of the jaw winking is gone with the excision of the levator. But in case, like as she mentioned during her talk, she said there may be a persistence of jaw winking, which is possible because we are not able to excise every fiber of the aponeurosis. So in that scenario, probably we don't have much to offer, but we have to rely on a complete excision of the levator. That's what would be very helpful.
Since we're doing sling bilaterally, I mean, in cases where we are doing sling bilaterally, do you also excise the LPS bilaterally?
No,
it's ideal if in case you have, it's usually a unilateral situation. And if the situation is unilateral, it's very difficult for us to convince a parent. This is usually a parent who we have to convince. No parent is going to be very willing to subject the child to a surgery in a normal eye. So I have personally not been able to convince parents. Probably I'm not very good at counseling. But even if we had to do a unilateral procedure, I think as what Dr. Meenakshi has mentioned, it's ideal to position at the level of the limbus, which is what would be an ideal position. In case you get to do it under local anesthesia, then probably a comparative procedure would be ideal.
Thank you, Dr. Kim. Dr. Maya, would you like to add anything?
Yeah, I agree with ma'am that in sling we usually put it at the limbus only because they tend to, stretch with time and tend to come down over a period of time. So at the limbus is the ideal position.
And points with regard, I mean, your presentation was absolutely brilliant. It's just that we are addressing the postgraduates, and we should also focus on the questions that can be asked by the examiners as well. So the most important thing that the postgraduates have to remember is we normally tend to forget the horizontal aperture. We have to measure the vertical aperture as well as the horizontal aperture, probably an aborted blepharophimosis syndrome. But that apart, in an acquired ptosis, you also have a canthal dehiscence. And if you don't address the canthal dehiscence, wherein you attach the canthus, fixate the canthus, you probably are not doing justice, because you will not get a very good cosmetic outcome. You will just be correcting the ptosis, but you will not. So in order to rule out any of those situations, it's ideal to do a horizontal and vertical aperture measurement to start with. And then, of course, your margin reflex distance 1. There are many margin reflex distance 2 as well to rule out the lower lid ptosis also. And then you also have the most important MCD. Crease distance is very, very important, because that's going to determine a lot of things. Absence of crease is going to be in favor of a congenital ptosis, and a presence of a higher lid crease indicates an aponeurotic dehiscence, and you need to have that in mind. That apart, when your crease is absent, to augment your for investigations with tending to lean over to the congenital side, you can also do the lid lag on down gaze. If that is present, you are more in favor of a congenital ptosis. And you can also supplement with an eye lift test, where you have to evert the upper lid. And if it stays put for a very long time, you know that it's in favor of a congenital ptosis, where your levator is fibrotic. So it is not allowing your lid to come back to its normal position, which would be the case in a normal eyelid. And of course, then you have your levator action, which will be the basis for your plan of surgical management. So if your levator function is extremely good, and if there is minimal ptosis, then as you mentioned, a fascinella servate, which is a tarsoconjunctival resection. Not many favor it, but of course, there are many who continue to do that and have getting good results. Or your Mueller's resection, conjunctival resection would also be another option. And then, of course, you have your levator bordering between 4 to 12, where you have an extremely good levator action to a reasonably good levator action. You can titrate the amount of resection based on the amount of levator action. And for the less than 4 millimeters, as you rightly pointed out, you should go for a frontalis sling, which could be either fascia lata or any other material which is biocompatible, like the silicone material. Or in cases where materials are not available, you can even use a suture material, which is possible. Which are the questions which normally surface up in a postgraduate examination. And the other most important test you'll have to definitely mention is the Schirmer's test and the corneal reflex, which are both very important, because that also determines whether you would be able to go ahead with your frontalis surgery or not. And of course, as you mentioned, another phenylephrine test, which I think you also mentioned, in cases of Horner syndrome, it's going to be very, very helpful. And as you all mentioned, for the myasthenia ice pack test and the Cogan's lid twitch sign is another important test which can be done at the clinic level. But neostigmine test, you have to know as a postgraduate. You may not be doing it, but please remember that neostigmine test will have to be answered in the examination. And as far as other investigations go, visual acuity, mandatory, and you'll have to educate the parent that if there is an amblyopia, that's going to be the second stage of management. So you correct the lid height, and then you go ahead with the amblyopia treatment. Most often, that is not done, which has to be completed with the amblyopia management. So these probably are the other points which can be supplemented, but a very brilliant presentation, Dr. Meenakshi. Thank you for all your inputs.
Thank you so much.
Thank you so much, Dr. Meenakshi. Thank you, Dr. Kim. Dr. Maya, do you want to add anything to this?
Yeah, I always tell my postgraduates that all the oculoplasty long cases are most scoring, and ptosis is the most scoring case if you are lucky. So you must know all the steps of the detailed examination, as rightly pointed out by Dr. Meenakshi and added by Dr. Usha Kim, ma'am. Rule out pseudotosis. Whenever you are dealing with a case of ptosis in OPD, check for any vertical squint if there is any associated hypotropia. Sometimes just the hypotropia may be leading to, associated drooping of the lid. And if you correct that, the ptosis will improve on its own. Or there can be a double elevator palsy. So these are very important things not to be missed. Other than that, you have covered almost everything about this thing. How much is to be corrected while doing LPS resection? I usually check by the intraoperative lid margin position. Where do you leave it, rather than calculating by the Baird's technique preoperatively? So if it's a good LPS action, you can just leave it 2 mm below, and if it's a poor LPS action, leave it at the limbus. So that is how we usually practice. Other than that, almost I think everything is covered.
Just a few, two more things. Probably they would ask the difference between blepharochalasis and dermatochalasis. One occurring early in life with the papery skin. So that if the lid is very thin and if the skin is very papery, it is more in favor of a blepharochalasis. Whereas in dermatochalasis, it happens much later in life with fat prolapse. So these are two things. And maybe a little bit on blepharoplasty. Nowadays, people tend to ask a little on blepharoplasty, where it can be either just a pure skin excision, as in cases of blepharochalasis, to an extension of probably fat repositioning or fat excision, along with a bit of a ptosis correction in dermatochalasis. This is another thing. And of course, brow ptosis has to be, again, ruled out before you advocate any surgical procedure for ptosis. That is it. Thank you.
Thank you so much. Thank you so much, Dr. Meenakshi, and thank you to the panel. And congratulations, Dr. Meenakshi, on the crutch glasses patent. That's a beautiful design. Moving on, we will go to our next speaker. That is Dr. Raka Chatterjee from Sushrutai Foundation, Kolkata, who's going to speak to us about role of botulinum toxin in oculoplasty. Over to you, Dr. Chatterjee.
Good evening, everybody. Thanks to All India Society of Ophthalmology for giving me this opportunity to present in this podium. And my topic is botulinum toxin in oculoplasty. Now, botulinum toxin is a purified protein derived from a bacteria known as Clostridium botulism. Now, when injected into specific muscle, it blocks the nerve signals which make the muscles to contract. Now, the journey started from 1989, where it got its first FDA approval in the management of strabismus and blepharospasm. Then the journey continued. In 2002, it got its aesthetic approval. 2010, it was used in cases of upper limb spasticity in adults and chronic migraine. And still in 2025, we're having now extended use of botulinum toxin in oculoplasty. There are different serotypes of Clostridium, type A to G, produced by different strains of Clostridium. Types A and B are commercially produced. Commercially produced Elan Pharmaceuticals, Myoblock, that is botulinum toxin B, and Allergan produced Botox, and that is botulinum toxin A. They differ in their target molecule at presynaptic nerve endings, effective in cases of treatment failure with 1. Myoblock is for the use of treatment of benign essential blepharospasm in patients with refractory to Botox. These are all published in journals. Now, what are the different uses of botulinum toxin in oculoplasty? it has broadly two uses, two types of uses. One is a functional, another is the aesthetic. Now, what is the mechanism of action? Now, what happens during normal neurotransmitter release? Now, there are motor nerve endings and presynaptic vesicles. The synaptic vesicles contain the neurotransmitter acetylcholine. Now, at the motor nerve endings, there are snare proteins. They form synaptic fusion complexes. The synaptic fusion complexes help the fusion of synaptic vesicle membrane with the nerve ending membrane. And there is release of acetylcholine into the synaptic cleft. These acetylcholines then bind with the calcium channel-gated receptors on muscle cells and produces muscle contraction. Now, what are the different snare proteins? Three types of snare proteins are there: synaptobrevin, SNAP25, and syntaxin. Now, what happens during the injection of Botox? Now, when the Botox enters, the Botox actually is endocytosed. Now, the light chain of the Botox cleaves specific snare proteins. So, the synaptic fusion complexes are not formed. Type A, C, and E, that is causing the cleavage of SNAP25 protein, whereas the type B, D, F, G breaks the synaptobrevin. Now, whenever there is failure of formation of the synaptic fusion complexes, there is failure of fusion of the synaptic vesicle membrane with the nerve ending membrane, and the acetylcholine receptor is not released. So, the muscle contraction is not possible and the muscle fiber is paralyzed. This can occur anywhere. Now, in total, there are 43 facial muscles. Among them, 20 major facial muscles are important. Now, what are the different target muscles? Now, in oculoplasty, while we are dealing with the Botox, we should have an idea that what are the different target muscles where we do inject. We should concentrate on the frontalis muscle, corrugator superciliary, procerus muscle, orbicularis oculi muscle, and the depressor superciliary muscle. Among these, the frontalis muscle, we have to again see the origin, insertion, and the action of this muscle. To start with the frontalis muscle, it originates from the gallia aponeurotica and it's inserted into the skin of the eyebrows and the nose. The function is to raise the eyebrows and causing horizontal wrinkles of the forehead skin. The second important target muscle is the corrugator superciliary. It arises from the medial aspect of the supraorbital margin and it gets inserted into a skin under the eyebrow. It pulls the eyebrows downward and medially, creating vertical frown lines between the eyebrows, causing the glabellar lines. The third important muscle is the procerus. It arises from the fascia over the lower part of the nasal bone and it gets inserted into the skin of the lower part of the forehead in between the eyebrows and the frontalis muscle. The function is the depression of the medial part of the eyebrow, which creates the horizontal wrinkles. Orbicularis oculi is a very large muscle, arises from the frontal and the maxillary bone and gets inserted into the skin of the eyelid. It's a gross insertion. Now, action is blinking, squinting, forceful closing of the eyelids. Now, these muscles were important in causing different wrinkles, different clinical conditions like blepharospasm. Now, another few muscles I'd like to mention. These are some facial muscles apart from these muscles, and this produces different facial tics along with the closure of the eyelids. And number one is the levator labii superioris alignasi. It arises from the frontal process of the maxilla and gets inserted into the ala cartilage, the skin of the lateral nostril and the upper lip. This is the levator labii alignasi muscle. It has got two halves, the medial half and the lateral half. Next, the orbicularis oris. This is around the lips. This orbicularis oris arises from the maxilla and the mandible, and it gets inserted into the skin around the lips, and its function is to pucker the lips. And the transverse nasalis is this muscle, and it arises from the maxilla lateral to the incisive fossa, and it is inserted into the aponeurosis of the bridge of the nose. and it compresses and closes the nostril. Now, we treat frontalis with botulinum toxin to reduce and remove the horizontal forehead lines and to depress the eyebrows. Procerus as pulls the middle part of the brows downwards, and we treat them, this is the procerus, and we treat them to decrease the glabellar lines. The corrugator superciliary is the orange colored muscle here that is shown and is responsible for creating so-called 11 lines. We can treat this muscle with botulinum toxin to reduce its activity and to remove the angry expression and to restore a more relaxed and softer appearance. Orbicularis oculi is responsible for narrowing of the eyes. There's a green colored muscle here. If you close your eyes tightly, orbicularis oculi is doing the work. It pulls the eyebrows down, pulls the cheeks up, and creates the wrinkles around your eyes. You can relax this muscle with botulinum toxin to achieve the opposite effects. Now, what are the basic principles that we should follow while injecting? Number one, we have to maintain an ideal depth of injection. Now, what is that? It's just under the skin or at the junction of the dermis and the fat, if any, where there is a feel of release of resistance while we pass the needle. Deeper injections are to be avoided to reduce the diffusion into the unwanted areas. Like if it diffuses into the levator palpebris superioris, we'll have ptosis. If it diffuses into the extraocular muscles, we'll have diplopia. Or in the lacrimal gland, we'll have dry eye, causing complications. Now, injections on periosteum will cause pain. Now, while injecting, the injector should be well trained to have a knowledge about the anatomy of the local vasculature and the nerves to be, because if we prick in the local vessels, there will be a big hematoma. Or in the nerve, suppose we have injected into the zygomatofacial or zygomatotemporal nerves, then we have a clinical picture like facial nerve palsy, low motor neuron type of, with the drooling of food and water from the mouth, etc. Now, this not be very good feeling for the patient. We have to create a wheal. Now, the injected fluid should form a small visible wheal or bump under the skin to show correct placement. Now, the question is why the tape matters. Number one, efficacy. We are targeting the muscle fiber directly to ensure effective relaxation. Second one is a safety. It prevents the spread of the drug to unwanted areas to avoid complications. Superficial injection maintains some lower frontalis activity for a natural lift, especially in women, while deep placement might over-relax the entire muscle. So superficial one will have a better control over brow movement. There's some practical tips while injecting. Number one, feel the layers. You have to pay attention to the resistance your needle meets. Second one, distance from the orbit. While injecting in frontalis muscle especially, it should be 2 fingers above the orbital rib to avoid ptosis. Third one is the diffusion. Now, higher concentration, meaning lower dilution, it allows more precise placement. And second is lower concentration or higher dilution encourages spread. Now, what are the different functional uses of botulinum toxin? We have a long list. Usually botulinum toxin A and or B, commonly we use A. Now, what is the dose? Now, dose depends on the degree of muscle contraction that the clinician judges. Can be 1.25 to 5 units per injection site, and it takes starting effect after 48 hours, and maximum effect is seen in 2 weeks' time, and the effect can stay for 3 to 4 months. Again, this repetition of doses is individualized. The hypothesis is there that depending on the patient's metabolic activity, that's lifestyle. Suppose a gymnasium trainer, he will have a higher metabolic rate, so he will have more frequent administration. A person with a sedentary lifestyle having a lower metabolic rate can have less frequent dosing. Oral benzodiazepines, anticholinergics, levodopa, lithium, valproate are different medications given by neurologists in these cases, but many of the time it has been seen that patients are not tolerating or not responding. So the Botox is the ultimate thing here. And there are different articles where the role of botulinum toxin in the management of nephrospasm is quite evident. Now, apraxia of eyelid opening, and yes, it is another interesting condition where Botox is used. But as in blepharospasm, if you compare the patient happiness or the uh, outcome is much more better in treating with blepharospasm than the apraxia of eyelid opening. Now, again, coming to the hemifacial spasm, the second important common condition seen in our day-to-day practice. Here, the half of the face, see there is a twitching in the corner of the mouth in this patient, along with the forceful closure of the eyelids. Now, there is chronic irritation of the facial nerve fascicle and proximal nerve segment at the root exit area, which is covered only by arachnoid and not the epinudial. These patients are very susceptible to stress and compression by ectatic or aberrant blood vessels. That means the nerve is irritated with some blood vessels. Now, MRI is mandatory as a preoperative investigating tool. Now, different theories are there, like peripheral theory and central theory, or it can be secondary to Bell's palsy and some anomalous regeneration. Now, peripheral theory says that excessive firing is due to facial nerve demyelination at the compression site. The central theory says that irritation of the peripheral afferent facial nerve fibers leading to aberrant signaling to the central facial nucleus. The different investigations include detailed history, neurological and local physical examination, CT or MR angiogram, abnormal vascular loop close to the facial nerve, and EMG or electromyogram. The treatment is botulinum toxin A. Dose depends on the degree of muscle contraction, can vary from 1.25 unit to 5 unit per injection site. Repeat injection again depends on the metabolic rate of the patient. It is individualized. Different oral medications are there. The surgery if it is refractory to botulinum toxin therapy. Now, these are the some articles where hemifacial spasm is helped by injecting botulinum toxin. Now, what are the different injection sites? Now, this is a case of benign essential blepharospasm, where the different injection sites and the different target muscles. Here, these are the corrugator superciliary sites. These are the medial heads. And this is the injection site for procerus. Now, procerus, actually, we say it is a, if we can draw a line from the medial canthus to the medial end of the eyebrow here, and this side medial canthus to the medial eyebrow of the eyebrow here, the point of intersection is the site for the procerus. The corrugator sites are just above the eyebrow. We have to hold and lift the area before giving injection. That I'll show while describe the technique. Now, in the lower lid, there are two sites, these and these. Mainly, usually, commonly, we do not cross the mid-pupillary line with the fear of giving injection and causing medial ectopia. But in some cases, and few doctors are also advocating. Now, laterally, while dealing in the orbicularis area, there are 3 points. Here, these 3 points are there. Now, this is the lateral orbital rim. These points are taken about 1 finger breadth away from the lateral orbital rim. And the first point is the horizontal line. The second is 130-degree line. And the third one is the lower 30-degree line. And then the same vertical line, these 3 points are taken as shown in this diagram. Now, if we close the eyelid, on the upper eyelid, there are 2 points. And these are the pretarsal points, not the preseptal. If you inject it preseptally, it will diffuse into the levator, producing ptosis. Now, this principle is clinically taken advantage in cases of chemical tarsography, where we want to produce a ptosis, where the preseptal injection technique is followed. Now, these are the sites where we inject for the hemifacial spasm. In addition to the sites of hemifacial spasm, blepharospasm, we inject few extra muscles like levator labii superioris alignasi. Just a few minutes back, I told about the 2 heads of it. Can use transverse nasalis, can use in orbicularis ori, and levator labii, levator angulis oris is another muscle And depressor angulis oris is another muscle. Now, if we inject in depressor anguli oris, we have to inject in levator anguli oris as well. And the mentalis is the last one. Now, what is the procedure? See the wheel effect? Just little bump is produced. And the direction of the needle is away from the major structures like orbital rim. Now, how to reconstitute? Now, this Botox is available in a freeze-dried form. So we have to reconstitute before injecting. We have to reconstitute it with normal saline. Now, it causes pain if it is done with Ringer's lactate or sterile water. Now, the volume of the reconstituting material depends on the concentration of the drug we want to use in that case and the unit of botulinum toxin in that vial. Suppose we are taking a 100 unit vial. Now, if we want a 2.5 unit per milliliter concentration, then we have to dilute it with 4 ml of normal saline. Now, suppose we use 50 unit vial and we want a 2.5 unit per milliliter of concentration, we have to dilute it with 2 milliliter of normal saline. Now, if we want a concentration of 4 unit per milliliter and take an 100 unit vial, then we have to, we'll take a 2 milliliter of normal saline to reconstitute. And this reconstituted drug can be kept in the shelf of the refrigerator, that is 2 degrees centigrade to 8 degrees centigrade for use, and it can be used for a period of about 4 to 6 weeks. Now, we can inject the botulinum toxin in lacrimal gland. How to do it? We have to give local anesthesia and pull the lateral part of the eyelid with the help of a Desmus retractor, and then you have to inject into the lacrimal gland with the 1 ml syringe. Now, the dose in cases of watering, whether it is a gustatory epiphora, whether it is the watering due to punctal stenosis or common canalicular block or proximal canalicular block, to reduce the symptoms of watering or do the pump failure, the dose varies from 1.25 to 10 units. Again, it depends on clinician's assessment. It's a very simple procedure. So, role of botulinum toxin in epiphora, the results of lacrimal gland botulinum toxin injection for epiphora and lacrimal obstruction, gastritary hysteria. There is successful treatment of crocodile tears by injection of botulinum toxin into the lacrimal gland. The case reports are there. Chemical tarsography, just now I mentioned, in persistent epithelial defects in non-resolving corneal ulcer, where we can avoid surgical tarsography by giving this doing this chemical tarsography, and the botulinum toxin induced proptosis really help us. Paradoxical use of frontalis muscle and the possible role of botulinum toxin in permanent motor relearning. This is a case, these are the cases where there is persistent frontalis overaction following successful ptosis surgery. Botulinum toxin has some role. Now, lead retraction in thyroid-associated orbitopathy. Many of our time patients come with mild proptosis and for cosmetic correction. Minimal dose of Botox, even we can titrate and top up 1 or 2. We can give in the levator to produce mild ptosis, and lead retraction part can be taken up. Facial synkinesis can be treated after facial nerve injury with the help of botulinum toxin as well. Now, so far we were dealing with the use of botulinum toxin in different functional causes. Now we'll come to the uses of botulinum toxin in aesthetics. Aesthetics is a recent upcoming subject, and here the role of botulinum toxin around the eyes, mainly in 3 areas. One is the forehead lines, second one is the frown lines, and third one is the crow's feet. Now, the crow's feet are the lines in the lateral aspect of the eyes. These are the lines of crow's feet. These are the forehead lines, and these are the frown lines, means angry lines, 11 lines. Now, how the wrinkles are formed? Now, many facial lines form when we use our muscles to make the facial expressions. The lines formed during these expressions are dynamic wrinkles. Now, when dynamic wrinkles are left untreated in due course of time because of the repeated muscles action, they can form permanent lines on the face. Now, dynamic wrinkles can be treated with Botox or whatever, but the static wrinkles will not go with these injections. The peripheral periorbital features are the most scrutinized features around the eyes, and the upper face is the aesthetic center of the face, where we look to estimate the age, and the region we use to judge a person's emotional state as well. The upper face is one of the first to show the effects of aging. So if you want to look fresh, if you want to look younger, we have something to do in our upper face. Now, this is a new topic. So while dealing, I just told that there are three main indications in aesthetics while using botulinum toxin around the eyes. One is the horizontal forehead lines. Now here there is the in-pattern injection sites. Now, if you remember me, my few slides back, I told that while injecting in the frontalis muscle, at least 2 finger breadth above, we start injecting. And usually we do not cross the mid-pupillary line. So this is the vertical line that we should maintain. And there are 3 lines in the forehead. One is this is the inferior limiting line. This is the superior limiting line. And this is the superior, there's a hairline. Now, 2 finger breadths above the inferior limiting line. Here the 3 points. One is this vertical mid-pupillary line, one along this vertical mid-pupillary line, and in the middle. And this along the superior line, in the middle too. So this is a M pattern injection site. The concentration in aesthetics is little different from the functional, where benign essential blepharospasm or hemifacial spasm. Here we consider it and we give it in the dose of 4 international units per milliliter and per injection site. And the depth of the needle, where it is same as just the release of resistance just below the skin, and total dose can range from the areas here 25.4 each 20. Here the glabellar lines are dealt, the 2 corrugator superciliaris in the medial part, 2 points, and 1 in the procerus. Here also 5 points, the same 4 international unit per point, and again here total 20 unit. And the crow's feet, just mentioned the 4 unit here also. We can give it 2.5 depending on the situation. And to conclude, botulinum toxin has shown an exceptional efficacy in various ocular diseases such as blepharospasm, hemifacial spasm, as well as in facial aesthetics, as clearly supported by literature. Its minimally invasive nature of administration, versatile treatment modalities, and safety profile makes it an invaluable tool in contemporary ophthalmic and neuro-ophthalmic practice. These are my references. Thank you.
Thank you, Dr. Chatterjee. That was a very well concised topic, because Botox, it knows no limits. It's also growing. So there's so much that you had to cover. Very well presented, ma'am. I had a question. One was, a couple of patients may come back with no action or minimal action that has happened, and then they may want an augmentation of the drug. So at what point would you do this, and when do you ask your patients to follow up?
I tell all my patients that maximum efficacy will be seen. You can see after 2 weeks. Now, if this come back and tell me, ki, madam, a little bit is remaining, I request them to wait for another month and see, and then I top up. If there is total treatment failure, I may have to switch over to myoblock or the type B1.
When you top up, how many units do you give? Do you
That
have
again,
the
and
dose?
clinician minimum, clinical judgment.
Okay. Okay, sure. Thank you, ma'am. I would like to move to the expert panel for their comments.
She has actually covered it very extensively. But since you've given us the role of the panelists, we have to supplement. Dr. Raka, you did an excellent job. Just that few points from the postgraduate point of view, which you have actually thoroughly covered. Just a few points while reconstituting what measures do you take. You have to use the gentle rotatory movement and avoid foaming. That's very, very important. And the reconstitution, how would you do it? 100, it's available as 100 units or 50 units. 100 units is preferred mostly by people pooling up patients. So 100 units is what we prefer. And for 100 units, we use 2.5 ml of saline. This is the standard that we follow. So the concentration would be 4 units per 0.1 ml. So we take the tuberculin syringe. We use the tuberculin syringe, and that's one thing we have to remember. And when you mentioned about preparing the patient, it will be good to have the patient. You can use some anesthetic gel, and then sometimes you use an ice pack just to avoid any minimal pain also. I mean, these are patients when you're going for an aesthetic correction. I think you need to understand that they'll be very finicky about that as well. That's number one. And as far as preparation goes, I think that's all we need to do, and it doesn't have to be in the operating room. It can be even on your clinic side. The other thing I wanted to mention was we clearly have a distinct role to play in functional aspects, especially in what you mentioned. You had a very large list of functional aspects. But remember, there's one entity called the Meeks syndrome, where you have the entire face, which is twitching. And the other one is also the facial myokymia, which you have to remember. Both of which have to be very, very cautiously handled. One is originating from the basal ganglia, that is the Meeks syndrome. And the other one, you have to be extremely cautious because it could mean a glioma, pontine glioma, or sometimes even multiple sclerosis. So these are things that we have to deal with caution. That's why, as you mentioned, a thorough scanning is very, very important before we start any treatment. So it is also okay to get a neurologist opinion sometimes when you're in doubt. So these are the points that I think we should keep in mind. As far as aesthetic goes, I think you've really covered extensively, all of which has been completely covered. Yeah, I think now it's become everybody's tool. So I don't think it's just the ophthalmologist. Everybody is doing it, even in regular. But we need to understand the basics, and I think we have to address the postgraduates' perspective as well. That's all. Thank you, Dr. Raka. You did a great job.
In fact,
Thank
ma'am,
you.
thank you for mentioning that part, that a lot of people are doing it right now. And to my surprise, a person that I knew of in a meeting just said, I have done a Botox course online for 15 days. And I think it's just something that we often don't realize, and patients don't know about, the value of the right location and right place to do Botox. So I hope that we are able to break that by developing a good trust and balance with the patient. And we have to make them understand what's needed for them. We cannot really, talk about other doctors, but we should be able to, make sure that they're in the right direction with the right team. So, ma'am, what is your take on that, Maya, ma'am? I know that you experienced that too.
Yeah, very true. Means it's like a saloon thing now, so that practice has to be avoided. Of course, a professional and a clinician should give who is expert in this field. So for the postgraduates, I will say Dr. Raka beautifully covered almost everything. Yes, you need to differentiate whether it's an essential blepharospasm or there is a dry eye or any ocular surface condition which is leading to this spasm. So just rule out that first on your clinical examination. Then, as ma'am rightly pointed out, do a thorough scan in hemifacial spasm, and in fact, in apraxia of lid opening, also sometimes they are related with Parkinson's and other causes. So that should be ruled out. Then, while reconstitution.
I think we lost.
So
Maya.
always do it with the normal saline. So the pH matters a lot. And I have done it wrongly once, and I have experienced it. The patient experienced a lot of pain. So never do with the sterile water. Other than that, I think almost everything is covered. And about the the plane of injection, if you raise a blab in the subcutaneous plane, then you are sure that you have not gone deeper. Avoid the preseptal areas as pointed out. Avoid the medial lower part because that will lead to lacrimal pump failure. So just give in the central and the lateral part in the lower lid, and avoid a deeper injection in the lateral part that can diffuse into the lateral rectus, sometimes lead to diplopia. So just remain superficial, just know the anatomy well, and then it's nothing rocket science. Yeah.
And ma'am, another question I had was that, ma'am, do you end up titrating or like adjusting the dose a little bit? Have you noticed that after the first set of injections, when the patient comes back, they actually require lesser dose? And also, do you see resistance developing in these patients?
So it's always better to start with a minimal, effective dose. You can always, titrate it in the second sitting. Patient will always be happier because he was having a lot of functional problem, and whatever you do will be beneficial. So if you see that this particular muscle is, still having the contraction in the second sitting, you can top it up. So I usually for my spasm patients, blepharospasm patient, I started with 2.5 units per injection site, and then later on you can adjust according to the response. So that is how I do. Resistance usually I have not seen in many cases. If it develops, then you can switch to other toxins like Xeomin or other Dysport, other things are there, so that you can switch. Yeah.
Right. Dr. Shahid, sir, are you there with us too right now? Right. Dr. Usha, ma'am, do you also feel that you don't develop, you
Yeah,
don't?
rolling. Oh, okay.
Yes, sir.
Sorry.
Yes, sir. Yes, sir, Shahid, sir.
Yeah, I'm there. So no, I just had Usha ma'am is there.
Very
Yes,
much.
sir.
Ma'am, actually, I did a sort of an experiment because I have a lot of these kind of patients, not aesthetic, functional. There's blepharospasm and
Right.
hemifacial spasm, apraxia, mixed syndrome, Bruegel syndrome, and they keep coming. Like every 6 months, they'll come for this injection. So I thought once that, especially in case of blepharospasm, the majority of the spasm is in the upper lid. So if I just give Botox to the upper lid and leave the lower lid as such, and if it works, the dose will be halved for at least for the patient. So I tried in 2-3 patients, and it didn't work at all. It didn't work at all. A patient came back after 2 weeks, after 1 month, and the spasm was almost the same. Didn't relieve a bit. So the conclusion is that the whole of the orbicularis, both of the upper lid and lower lid, especially in these diseases, works as a single unit, and the contraction force is so severe that even I had paralyzed the pretarsal, the oblique of the upper lid, but that even that lower lid force, that transmitted force was enough to completely close it. So that was a small thing like I wanted to share.
Right,
And
sir.
like it's a topic like I like a lot. I read a lot about these muscular dystonias, and
Right,
the
sir.
only thing is like we haven't got a great breakthrough apart from this Botox. But yeah, there are few patients who have like complete remission with these neuropsychotic medications, these benzodiazepines, anticholinergic, that Rivicon. There are a few patients, especially those who have Meek syndrome and associated neck dystonias. So
Right.
there are few, like quite a handful of patients who have like they are now off Botox and only on medications.
Right. Thank you, sir. Thank you for sharing your experience, sir. And Usha, ma'am, my question to you was that In the patients that you have resistance, what has been your experience with Xeomin and Dysport?
I feel if there is resistance, there's going to be resistance.
Right. Okay.
Yeah. So, as was mentioned, in some of the cases, I've actually tried doing a sling.
Okay.
Yeah. Just to elevate and let the patient functionally, for the functional aspect alone.
Right.
Because most of the time, these spasms are so severe that they're completely functionless, meaning they're not able. So I've tried a couple of cases where I've done a sling and it seems to work. I somehow feel this resistance is going to remain resistant. It is like the complete blackout in all these muscles, I feel. Completely they get knocked off and don't ever respond to any of these. So this has been my experience. I'm not sure of the rest of the people, but I've tried this.
Yeah, I agree.
Right.
What is your take on orbicularis myectomy?
You can do it. It's an extensive procedure. And what if? That's the question. So I have tried actually a couple of cases. If it's relatively simple and mild, I think it works. But if it's extensive, again, the question of how much
you'd be able to get.
Dr. Bhupi Patel has done extensively. Dr. Anderson has also done quite a bit on that. And I've seen them do also. It's quite extensive. And I've tried a couple of cases. But I think a simpler option, you can try this probably.
Right.
It has worked in a couple of cases.
Right. And to answer to my ma'am's question, ma'am, actually, we have noticed in some of our cases where there was Botox resistance, as ma'am said that, in those patients, when we did selective myectomy, we saw a very good response in our patients. Like they were more comfortable, especially with the fact that they did not have to receive Botox every 6 months. So the basic thing that they said was that we got final relief from the spasm. And we were being very selective with the myectomy and not very extensive, so that it's not like too much to go. And it works pretty well. I mean, the feedback that we received was they're finally done with it, because every 6 months getting an injection done was more hectic for them. But myectomy kind of relieves the psychosocial aspect. So that was what we have observed. Right. Thank you so much. Thank you, everyone. And Ananya, do you want to say anything before we close? You've been
I'd like to thank all the speakers. I think this is going to be like a one-stop solution for all PGs to know their oculoplasty long questions or vivas.
Absolutely.
It is so well covered and so well explained by all the panelists as well. Thank you so much for making me a part of this.
Of course. Thank you, everyone, for taking your time out on a Saturday night. And I know that a lot of you are in conferences and taking out time. Thank you, ma'am, also, for just making sure that the session runs very smoothly. Thank you, Usha ma'am, for joining us. Thank you to the speakers. And thank you for my co-moderator to help me out for the session when I was also out of network. So thank you, everyone. Have a wonderful night. Thank you, Sunil ji, for the technical coordination. Thank you, everyone.
Thank you. And good night.
Thank you so
Good
much.
night.
Yeah.
Thank you. Good night, everyone.
Good.